Most people treat painkillers the way they treat any other tool. You use them when you need them, they do the job, and when the job is done, there are no lasting consequences. For occasional use in genuine pain situations, that picture is largely accurate. But the pattern of use that has become normal in much of the developed world is not occasional, it is regular. Ibuprofen taken after every hard workout, paracetamol taken at the first sign of a headache before waiting to see if it resolves. Anti-inflammatory medication used preventively around physically demanding activities. Low-dose regular use that feels mild because the individual doses are small, but that produces biological effects that compound over time. The two most commonly used over-the-counter painkillers, ibuprofen and paracetamol, work through entirely different mechanisms and have entirely different biological consequences with regular use. Understanding those mechanisms changes how you think about when these medications are genuinely appropriate and when they are working against the outcomes you are trying to achieve. This is not an argument against painkillers. There are situations where they are clearly appropriate and where the benefits substantially outweigh the costs. This is an argument for understanding what they are actually doing, so that you are using them deliberately rather than habitually. Ibuprofen belongs to a class of drugs called non-steroidal anti-inflammatory drugs, or NSAIDs. Its mechanism of action is the inhibition of enzymes called cyclooxygenase 1 and cyclooxygenase 2, COX-1 and COX-2, which are responsible for the production of prostaglandins. Prostaglandins are signaling molecules that play a central role in the inflammatory response. They sensitize pain receptors, which is why inflammation hurts. They cause vasodilation and increased vascular permeability, which is why inflamed tissue swells. And they drive the cellular processes, the recruitment of immune cells, the activation of fibroblasts, the stimulation of tissue remodeling that actually repair damaged tissue. By blocking prostaglandin production, ibuprofen reduces pain and inflammation. This is the intended effect, and in the context of acute injury or chronic inflammatory conditions, reducing prostaglandin signaling can meaningfully improve quality of life. The problem is that prostaglandins are not only involved in producing the uncomfortable symptoms of inflammation, they are essential signals for the repair process itself. When you take ibuprofen after a muscle strain or a stress fracture or a tendon injury, you are not just reducing pain. You are blocking the signaling that tells the body to begin the repair sequence. Research on this has produced findings that are more significant than most people who use NSAIDs regularly have ever been told. A study published in the Journal of Bone and Mineral Research found that ibuprofen use after bone fracture significantly delayed bone healing compared to placebo. The animals treated with ibuprofen showed reduced callus formation, the initial bone bridging that precedes full healing, and lower bone mineral density at the fracture site at multiple time points. The healing was not just slower. The quality of the healed bone was measurably inferior. Research on muscle repair has produced similar findings. A study examining muscle recovery after exercise-induced damage found that NSAID use blunted the satellite cell response. Satellite cells are the muscle stem cells responsible for muscle repair and growth after exercise-induced damage. The inflammation that NSAIDs suppress is not only the cause of post-exercise soreness. It is the primary signal that activates the repair and adaptation process that makes exercise beneficial. This is the central paradox of taking ibuprofen after training. The soreness you are trying to eliminate is a symptom of the same process that makes the training produce adaptations. Suppressing the inflammation reduces the soreness. It also attenuates the adaptation. The exercise stimulus is delivered. The response to that stimulus is blunted. A 2017 study published in Acta Physiologica followed young adults through a resistance training program. One group took ibuprofen at the maximum over-the-counter dose after each session. The other group took a low-dose aspirin. After 8 weeks, the ibuprofen group had significantly less muscle hypertrophy than the aspirin group, despite identical training. The drug that was reducing their post-workout inflammation was also reducing their gains. This does not mean NSAIDs should never be used in the context of training or injury. For acute injuries where pain is severe enough to limit movement, short-term NSAID use may allow rehabilitation to proceed more effectively than if it were not used. The calculus changes with severity. A sprained ankle that cannot bear weight may benefit from a short course of ibuprofen to allow early mobilization. Muscle soreness after a gym session does not meet this threshold. Paracetamol, known as acetaminophen in North America, works through a completely different mechanism, and its risks with regular use are concentrated in a different organ system. The precise mechanism of paracetamol's analgesic effect is not fully understood, which is unusual for a medication that has been in widespread use for decades. It is known to have central nervous system effects. It appears to modulate pain signaling in the brain, and it has some inhibitory effect on prostaglandin synthesis in the central nervous system, though this effect is weaker and more selective than that of ibuprofen. What is well understood is what happens to paracetamol when the liver metabolizes it. The majority of a paracetamol dose is converted by the liver into harmless compounds and excreted. But a small fraction, approximately 5 to 10%, is converted by a liver enzyme called CYP2E1 into a highly reactive and toxic metabolite called NAPQI. Under normal circumstances, NAPQI is rapidly neutralized by glutathione, a powerful antioxidant produced by the liver, and the toxic metabolite is safely cleared. The problem is that glutathione is not an unlimited resource. Each dose of paracetamol depletes a portion of the liver's glutathione stores. Under normal dosing conditions with infrequent use, the liver replenishes glutathione between doses and the system remains in balance. With regular or higher dose use, glutathione depletion begins to outpace replenishment. When glutathione is depleted, NAPQI cannot be neutralized. It accumulates, and NAPQI in excess causes direct damage to liver cells through a process called oxidative stress, the same category of cellular damage that antioxidants in general are designed to prevent. In severe cases, typically from overdose, this liver damage is lethal. Paracetamol overdose is the leading cause of acute liver failure in many developed countries. But the concern with regular use is not acute liver failure. It is the cumulative effect of repeated partial glutathione depletion on liver function over time. The liver has significant regenerative capacity, and modest regular paracetamol use at recommended doses does not produce clinically obvious liver damage in most people. But research has shown that regular paracetamol use is associated with measurable elevations in liver enzyme markers, even within recommended dosing parameters, a signal of ongoing low-level liver stress. Glutathione is not only a liver-specific molecule, it is one of the body's primary antioxidant defense systems, involved in neutralizing reactive oxygen species in multiple tissues, including the brain. Chronic depletion of glutathione through regular paracetamol use has implications that extend beyond the liver, for immune function, for neural tissue protection, and for the general antioxidant capacity that protects cells from oxidative damage. There is also a recently documented effect on psychological function that was not anticipated when paracetamol came into widespread use. A 2019 study published in Social Cognitive and Affective Neuroscience found that paracetamol reduced not only physical pain, but also the emotional pain of social rejection, and simultaneously blunted positive emotional responses to pleasant stimuli. The participants who took paracetamol reported less emotional distress in response to negative events, but also less pleasure in response to positive ones. The drug appears to produce a generalized blunting of emotional experience, not a selective reduction in pain. A separate study found that paracetamol reduced the capacity for empathy, specifically the ability to feel concern in response to other people's pain. These effects on emotional and social cognition are not what most people consider when they take paracetamol for a headache. But they are real, they occur at standard doses, and with regular use they become a persistent feature of the user's psychological environment. The question of when painkillers are genuinely appropriate deserves a clear answer. NSAIDs are well justified in several contexts. Acute inflammatory conditions, rheumatoid arthritis flares, acute tendinopathy, where persistent inflammation is itself causing damage rather than facilitating repair. Acute injuries where pain is severe enough to prevent necessary movement, and where short-term use allows rehabilitation that would otherwise be impossible. Dental pain, which involves a specific inflammatory mechanism that NSAIDs address effectively. Post-surgical pain management under medical supervision, where the alternative to NSAID use is opioid analgesics with more significant risk profiles. And fever reduction when fever is genuinely causing harm, though moderate fever is itself an adaptive immune response that accelerating antipyretic use may inappropriately suppress. Paracetamol is well justified for pain that does not involve significant inflammation. Tension headaches, mild to moderate pain from non-inflammatory causes, where the prostaglandin blocking mechanism of NSAIDs is not needed and their side effect profile is therefore not worth accepting. It is also the safer choice for people with gastrointestinal conditions, since ibuprofen's COX-1 inhibition reduces the protective prostaglandins that maintain the gastric mucosa, increasing risk of gastric ulceration with regular use. The situations where neither medication is well justified are more common than most people recognize. Muscle soreness from exercise is a normal and functionally important response to training stimulus. Suppressing it with NSAIDs costs more than it gains. Mild to moderate headaches that resolve with hydration, rest, or simply time do not require pharmacological intervention. Routine minor pains that are more inconvenient than limiting are being treated with medications whose biological consequences are not trivial simply because the medications are available, cheap, and culturally normalized. Here is the synthesis. Ibuprofen and paracetamol are effective analgesics that have genuine roles in pain management. The concern is not their existence or their use in appropriate contexts. It is the normalization of regular use for minor symptoms in situations where the biological cost of that use is not justified by the benefit. Ibuprofen taken after every workout is suppressing the inflammatory signaling that the workout was designed to produce, reducing both soreness and adaptation simultaneously. Paracetamol taken at the first hint of a headache is depleting glutathione, blunting emotional processing, and reducing empathic capacity for the management of a symptom that, in most cases, would resolve without intervention. The practical reframe is not to avoid these medications. It is to use them deliberately, for pain that is genuinely limiting function, for inflammatory conditions where the inflammation is pathological rather than adaptive, and for durations that address the acute need without becoming a chronic habit. The body's pain signals are information. Sometimes that information is a false alarm, or is disproportionate to the underlying issue, and treating it pharmacologically is appropriate. But often it is accurate. It is the body signaling that something is happening that requires a biological response. And in those cases, suppressing the signal without addressing what it is communicating produces outcomes that are worse than tolerating the discomfort. Understanding what these medications actually do, not just that they reduce pain, but through what mechanisms and with what consequences, is what makes the difference between using them as a tool and using them as a habit. If this gave you a different way of thinking about reaching for a painkiller, hit the like button. Share it with someone who takes ibuprofen after every training session.